So I'm going to talk today about ultrasound the critically ill neonate, and I'd like to give you a little bit of what we're doing with it and where the evidence, some of the evidence is for what we're doing. And as you know, there may not be a lot of evidence for some things we're doing, but some of it just makes sense, and more evidence is coming. So I have no conflicts of interest. If I did, everybody would get an ultrasound at the end of your desks, if only. So in the NICU, we're still behind from a point of care ultrasound standpoint. So we don't also have bladder scanners, which many of the other units have just readily available. We don't necessarily have that in the unit. So we'd have kids with moderate HIE, hypotension, they're not peeing. So we don't know if you should bolus, do a place Foley. We've got kids undergoing UVC placements, and this can take a long, long time. So there are some of the community hospitals, some are delivery hospitals where within my current system, where it can be hours to get your first x-ray. So it can delay your times to have your top down for these preemie kids, and it can really be an impediment to some of the care that we're trying to do. And the great thing about neonates, and they are really great to image. There's minimum body fat, small size, you put a small probe on the lung and you see the entire lung. There's open fontanelles, the LPs, there's no that bone obscuring it. We get beautiful views. And it's starting to really give us a lot of information. So why not use it for the neonates? And from a history of POCUS, I mean, you all are well aware of this. It's been around for a long time. We've been doing POCUS for decades for clinicians. The EDs had guidelines since 2001 and PEDS-EM 2015, SSEM 2016, and up and up. But from a neonatal standpoint and a PEDS standpoint, it's becoming more and more utilized. So this was a joint effort between PICU, NICU, ED to talk about diagnostic point-of-care ultrasound. It's growing. We should be doing diagnostic point-of-care ultrasound. It just wasn't present as much. In 2020, this is one that's often referenced. This was an international evidence-based guideline that Yogan Singh and colleagues, including some our colleagues over, I think Thomas was on this one, and Maki Fraga over at CHOP, talking about what are some evidence-based guidelines for POCUS for the critically ill neonates and children. And this really got people, more and more neos, there was already interest in this just further developed, said, we really should be doing some of these for neonates. But we're really behind. I keep saying this, but we are. Now, this survey was done in 2016 and 2017. There's actually another survey that at this recent PAS meeting, the data has been collected or is going to continue to be collected, and then we should hopefully have some results out for where we are, where the status is now, and what we need for program development. But this time the survey was done in 2015 or 2016, 2017, the access to machines, and these are for those that replied to the surveys, the access to machine much less than the PICU, NICU 63%, PICU 97%. The use was much less, and fellow training really much less. And some of the barriers that came up was there was a lack of training to be able to do this for starting a program and both utilizing and starting a program. There were some things I thought really we needed a collaboration in radiology. We needed appropriate credentialing to be able to do to do neonatal POCUS, and then policy statements. And without those, people were really reticent, the neos were really reticent to start it. But if we had those things in place, then people wanted it, but they wanted a little bit more direction. So this document that came out in 2022 was a really landmark document for us. This was from the AAP. There was a clinical and technical report. So two that came out from the AAP section, neonatal perinatal medicine, the coffin statement, so the committee statement, through the AAP in conjunction with the radiology section as well, talking about the use of point-of-care ultrasound in the NICU for diagnostic and procedural purposes. And it really highlights that, this is important. You should have program development. You should have, this was out from that article, you should have education, figure out your applications are, have education, QA review, clinical workflow, institutional credentialing. And it gave a bit of a framework, and at least talking through how we can develop this, and also what indications could we use for neonatal POCUS. And this helped. What we were able to do with this document is, I know I sent this on to my leadership, others sent it on, because there's really a lack of machines. And I know on the PICU side, you guys had been doing ultrasounds for procedural based and diagnostic, but procedural based with machines without an issue in the unit. The NICU just wasn't there. When we started our program, we borrowed from cardiology. We had this old M turbo that would turn off every once in a while during an image, which was great, but at least it was better than nothing. And we had a hand-me-down GE from laptop from cardiology. So that's how we initially had our machines. But once we started a program and we were able to get some grant funding and started, then we started from an educational standpoint. And this was Faith Myers, who's graduating now, will be starting in Minnesota and doing POCUS up there as well in the NICU. She tracked along, and we started the program at Stanford in 2018. And she tracked the use of ultrasounds. We had REDCap database by the fellows, and it increased over time. So they saw from 2019, 2020, all the way to most recent 2023, 2024, it really increased. And the types of ultrasounds they were doing changed over time with education and continued emphasis that this was a good thing to try to move forward. And it's continuing to catch fire. The Neonatal POCUS, so at the last PAS meeting, which is one of the bigger meetings that the neonatologists go to from a research standpoint, there were over 20, I think maybe at least 20 or 25, and I'm sure I missed some, abstracts on POCUS related from the NICU side only. And that included abstracts that were up and coming. So this is something that's definitely being utilized more and more in the NICU, and you'll be seeing lots more research, and sky's the limit on what we're doing right now. So from a use in the NICU, we use it for a lot of things, and many of these things are familiar to what you all use as well. So this isn't going to be completely new information, but the data that we're starting to come out is getting more, recognizing that this is really something we should try to utilize within our institutions. So I'll start with procedure ultrasound. I think Ben, I believe, talked to you all recently, right, Eric? So I'll just start a little bit with central lines, and you may have already heard a little bit about this, but our UVC placement by POCUS. So that situation that I talked to you, that I was presenting before with you all, that you put a line in, you adjust it, you wait for X-ray. I mean, that's for real. Whenever when I talk about that, people, that is definitely what happens. And this paper out, this was from Jay Kim, who's been a pioneer also in this ultrasound in the NICU. This was back in 2011 when he did this study looking at ultrasound umbilical vein catheters via POCUS versus standard. And the mean time for final placement was less, the number of X-rays is less, the number of manipulations for the UVC was overall less. And it found that, and we've seen that, and there's been numerous studies since, especially over the past few years, that has noted that the use of ultrasound time has decreased, was overall decreased, and the number of manipulations and X-rays obtained have decreased. And ultrasound is, just as you all can imagine, just better to see these tips than it is by X-ray. The projection, where exactly it's located. And so we started doing this actually, we were at Stanford. The way we started, which before pandemic, is we had a couple of nurse practitioners, attendings, and fellow attend the CHOP course in 2018. And then when we came back, one of the things we started with was UV placements and just UQI. And so we started 3 times a week just looking at UVCs and tracking to see where they were, and does their X-ray correlate with where the UVC was, or do you think it's malpositioned? And we definitely found malpositioned lines. And actually, we have a text thread with our POCUS program here, and at one of the delivery hospitals, one of the fellows and attending texted and said, there's something that's strange. This line looks like it's in the liver. On X-ray, they say it's okay, but it looks in the liver, and it looks like there's echogenic material around there. And that line was not in the right place. So they were doing education ultrasound for a line that was supposed to be in a good place, and it just wasn't. So just emphasizing this, POCUS is better for looking at these lines than X-ray is, and we should be doing them more. Ben talked to you all about this, I believe, the real-time ultrasound guidance. This was done on the study we did as a multi-center study on cardiac patients to try to redirect these UVC lines, and we're pretty successful. For lines that were placed in the first 48 hours, and these are all lines that had failed initially, we were successful in 80% in getting those lines placed in the first 48 hours. It was less as time went on. And so we can in the NICU, we talk about, you push on the liver, you twist and try to guide this line, and you can really see it by ultrasound. And so it's amazing to me when we look at these floras and look at my ultrasound, these lines ever really get in when you're thinking about going from the umbilical vein and you're trying to get it through this ductus venosus and up to the RA. And apologize for this early, but this was early on one of those machines that didn't save for us. But you can see here's the umbilical recess. It's the phase array probe, the ductus venosus coming through here. And you can see that line coming through the ductus venosus into the RA. And you can try to direct that. It straightens out. When you push on it, you straighten it out, and you can flush a little bit before you go in to try to dilate out and compress the other portal veins or the hepatic veins in there. We also can teach this by linear probe. So linear is another method that we can use this. Sometimes I've actually we've had better luck with that also on the more preemie kids. But there's actually, so since that's come out, I don't know if it's been quite published yet, but I know other institutions have done placement on their preemies with ultrasound guidance. So not just the cardiac kids. So it's something we should really consider for our population, especially for those when we can't get the lines in. From an LP standpoint, you're all familiar with this data, but it's higher success rate for ultrasound-assisted lumbar punctures. And when we started doing them, and what people have noted is that they really like to be able to see what the fluid looks like, if there's hematoma back there. For our fellows, when we started teaching that, we were doing static only. We hadn't quite started dynamic LPs yet. But even with static LPs, we were having some more comfort with doing the LPs. And we're looking at the data now to see if that's translating. But I know there's a nice study out from CHOA that's going to be, but I think, finished collecting data. So that will be coming out as well on the use of ultrasound with LPs. And it's just, we get beautiful images of the neonate. Without the ossification, you see the conus so nicely, so we can do our markings really easily. And we don't have that blockage I know in some of the older patients that have. This was a nice study out, a very early study that was looked at neonates that were referred after a failed LP to radiology. And what they found was that 23 of the infants that had echogenic, had an intrathecal or epidural echogenic hematoma. They performed 9 LPs. One had no sample, 8 with only blood. And this is ultrasound guided by radiology. And these were deferred or canceled in many of the cases. The other ones really didn't get much fluid. So with that, what I've found to be helpful too is just to look and see if there's been a bloody tap before. Is there actually a hematoma that's present that would give us an indication that we're not likely to get it? The baby's already on antibiotics, so we defer for another day, and I've talked to the teams about that. Or does it seem like you can go below a space or above a space and get around some hematoma? So I felt that I found that to be pretty helpful. And then recently, Maki and Jason over at CHOP, neonatologists there, who are leaders in this field and POCUS as well, have published on the real-time ultrasound guided lumbar puncture in the NICU. And so what they found is that the overall success rate was 100%. So they did 17 and 100% success rate. So, there's not a lot of places that are doing dynamic just yet, but this was able to demonstrate that they could do this safely, have better success overall, and then pretty good success from a non-traumatic LP rate. So something else for us to consider. Suprapubic aspiration. So we in the NICU have really gotten away from suprapubic aspiration. From a comfort level, more did in and out calves. Feel like, well, you don't have to do a tap on a baby, you don't have to puncture the skin and just do the catheterization. But really, overall, these can be done very quickly with the suprapubic, and not a big surprise. By ultrasound, it's better than a blind approach. So overall success is much better. And I'm surprised by this. And one is that, of course, with ultrasound, you can detect if there's urine in the bladder. But I've been surprised by, for one of the patients we had a patient with bladder outlet obstruction, so we needed to do some, get the urine out. And we did a tap and we imaged, and it's like it was going to be a huge, didn't think you could really miss it, but the baby had a kind of abnormal anatomy. So it's okay, well, there's a lot of fluid in there. Let's go ahead and do it. But we didn't quite do it under ultrasound guidance. I can't remember the reason why we didn't, but maybe it's a sterilization reason. I can't remember why, but they did it, and then we still didn't get the urine. So we ended up doing it under ultrasound guidance and got out over 100 cc, like 100 cc's, which is crazy amount for a new, few days old kid. So ultrasound is useful. I mean, we could do it, and I've done it both in the smaller kids. We can actually do it with virtual convex linear phase array. can be good. The issues I have with phased array is that it tends to cut off a bit of the bladder. So I've used virtual convex with that, or a linear probe can work well in these kids as well. And doing a virtual convex can sometimes extend your borders out a little bit more. And then thoracentesis. So we've actually had one of our fellows at the time was at Stanford, Carolina, who took a POCUS machine at the DR. When a baby was coming out with high drops, and she very quickly, baby came out and they resuscitated, so it wasn't slowing anything down. She put the probe on, had her catheters ready, and this baby had very significant ascites, and so she was drained in the DR. And quickly scanned for cardiac and lungs to see if there was much fluid there, and there wasn't at that time. It was massive ascites. But we also noted when she came back that the liver just looked really abnormal. So that noticed that initially, and she had a full workup. Maybe had a full workup also, but pre and post thoracentesis in the DR, she was able to pull that machine in and have it ready there and do it pretty quickly. So there's potential use, and the DR has not been explored a whole lot from neonatal literature standpoint, but there's some work on heart rate monitoring the DR with ultrasound. So that's a field that's got a lot of potential there. So procedural, lots of things we can do procedural. From a diagnostic standpoint, so there's many things that we look at for diagnostic. I talked a little about UVC already. ECMO cannula position is another one, especially when we're thinking about our patients with VV cannulas, where their right atrium is the average size or mean size for the first month or so is about 1.6 centimeters. It's really pretty small. So you put a venous cannula in there, it's going to move around some. So being able to look at cannula position can be helpful. Cardiac, lung, ET tube placement, head ultrasound admin, and other things that we're going to continue to work and develop. Now, there is a pretty significant learning curve for POCUS from a diagnostic standpoint. Head, as neonatologists, we are really used to seeing head ultrasound. It's nice and open in here, and actually in Europe, that's part of their routine is the neonatologist will do head ultrasounds pretty routinely over there. It's so head ultrasound is low from a difficult standpoint, and then functional echo, which I'll talk some more about in a little bit, is a little further down in what you need from a training and adjudication standpoint. So diagnostic cranial ultrasounds, I say we have a nice benefit of having a open fontanelle that we can look at these kids pretty readily and easily. And so the things that we're looking for and we're considering for cranial ultrasound is we're looking for big things. And I've used it before for patients that have an acute decompensation, their heart, they may have tachycardia, they're becoming tachypnic, they're acting like they're in shock, and done a quick scan and seen pretty significant bleeds on our preemie kids. And so it can help to potentially bring radiology sooner. It can detect if you have big ventriculomegaly or changes in there and prompt ultrasound sooner. So that's, and teaching from that standpoint, there actually are some certain points that you do for if you want to do more specific measurements, and that may be a little bit more advanced than what we're trying to look at, which is for when you're thinking about basic POCUS is really just one of the big changes and one of the big things we want to see. And a head bleed is certainly something that can affect our preemies and lead to decompensation. Now, lung ultrasound is becoming really, really big in neonatology and trying to identify and really learn more about how we can use lung ultrasound in our neonates, not just for pneumothoraces and effusions, but also to look at parenchyma and help us with surfactant deficiency. So there are different pathologies that we can look at from a neonatal standpoint. So transient tachypnea of the newborn, those first couple of days when they need some time to get the fluid out of the lungs, and they may transiently need a little bit of support, compared to RDS, where you have these babies that have surfactant deficiency, and they're going to have a more prolonged course in those kids with TTN, even though they may look somewhat similar. So ultrasound can help us to differentiate that. Meconium aspiration syndrome, lung ultrasound can look pretty different with that. Pneumothoraces, pneumonia, and there is increasing literature. And I should look now in 2023. I looked like, I was trying to think of how many. So there's more. There's a lot more. It's exponentially increasing on how many studies and how many people are looking at lung ultrasound. Because there's so much we can look at, and the diagnostic capability of full lung ultrasound takes less than 3 to 5 minutes. I've had to slow down my NPs previously because when they did the ultrasounds, it was too fast. Actually, when we did prospective clips, it was too fast that we were moving off before I can clip the whole image. Now, Europe has been very ahead. The NICUs in Europe, and Dan DeLuca has been a big mover for lung ultrasound and early utilizer for lung ultrasound in Paris. And so there's a lot of literature coming out from them. And they introduced lung ultrasound in 2013. And in 2014, they had a protocol for use of ultrasound as a first-line imaging for all babies admitted to NICU with respiratory distress from 24 to 36 weeks. And these numbers seem crazy to me because I can't imagine that this many patients would not have an X-ray. But I've asked, and it is for real. There are much less X-rays that are done, and some that only have one X-ray that's done for their stay. And some of these patients, they'll do surfactant. They won't necessarily get an X-ray when they hit. All of them, when they come in, will get an ultrasound. They may not be getting X-rays because they're doing ultrasound for lungs, they're doing ultrasound for lungs. So it's amazing to me, and I'd love to be able to get to a point where we're really using ultrasound really in that way that we can eliminate or really decrease our radiographs. So and lung ultrasound just gives us such a better view than doing our plane of view X-rays. So this is a 6-week-old patient, X27 weaker, CPAP of 7, and his X-rays on the left, and on the right, he's actually got coalescing B lines. We see some movement in here. It's a little older baby, so you can see we have some ossification. The pleural line maybe looks a little bit thickened, but this is not a very, there may be some edema in here. There's potentially some, maybe some fibrosis. We're still going to learn some more about the pleural line. So that's a whole lot research needs to be done there. So lung ultrasound, we can see things clearer. Now, pneumothorax, of course, this is one that we have definitely utilized POCUS for. And this was a study out from the Europeans looking at lung ultrasound accuracy for pneumothorax. And they, across the board, found everything 100%. It was really good. After sudden decompensation, the average time for lung ultrasound is average about 5 minutes. Chest X-ray average about 19 minutes. And they were able to drain the pneumo after ultrasound before radiography in 9 cases. So it can be done faster, and we've seen that as well. So this is where it kind of gets really interesting too, and different from a neonatal standpoint of lung ultrasound scoring. So this was the Paris group with Dan DeLuca published this data back in 2015, looking at, and this is the scores that we use really now, is looking at lung ultrasound scoring, and we use 6 fields. For the standard, we use 6 fields. There's other scoring pathways that may be different, but standard we use 6 fields. So right side, 3, right upper, right lower, and then lateral, left upper, left lower, and lateral. And you can have scores ranging from 0 to 3, 0 being well-aerated A lines, B or 1 is more than 3 B lines, 2 are coalescing, and a score of 3 is if you have consolidation more than a CM. And so when you add those up, your scores can range from 0 to 18. And so what they found is that they, when they used lung ultrasound score, they were able to predict surfactant need. And so they would predict that the need for surfactant dose in those less than 30 weeks, and they did these pretty quickly after they came out of the DR. So need for surfactant dose, lung ultrasound between 6 and 8 for optimal sensitivity and specificity. So generally talk about if you have an 8 or more for lung ultrasound score, then you probably need some surfactant, and they'll go ahead and give that. And then if the lung score was greater than 10, that would be an indication they would end up needing surfactant redosing. We'll oftentimes give it once, and then potentially, depending on how the baby looks, we may give it again, depending if they're intubated and still seem to have significant requirements. And so that has not been, they've been doing it in Europe for a while, and there've been a lot of discussions of, well, is that changing your BPD rate? Is there? And so, it hasn't been taken over in the US just yet. But I think more groups are interested in looking at their lung ultrasound scores, and even from observationally, is this changing? Is this giving us an indication they have surfactant need? We've seen anecdotally that's happened, but something we're going to hopefully be starting at our delivery hospitals. So we'll see if there's any interesting findings there. So the other thing that's been interesting, we looked at this to look at if we can utilize lung ultrasound as an adjunct for determining whether babies were ready to come off CPAP or not. So typically we'll keep the kids on CPAP and give them that positive pressure for some lung development and growth. Oftentimes we try to do that until at least 32 weeks or so, just for further development and positive pressure. And when you try to take these kids off, they may lose FRC, they may take a long, have to have some recovery time afterwards. So we can identify if these patients succeed off it, that would be helpful. And so we looked at our population of patients that we had scanned pre-CPAP discontinuation to see what their scores were pre-CPAP discontinuation, and look to see did that help us to determine if patients needed to come off CPAP. And we found that it did. So if they had an absolute score less than 4, that was a pretty good predictor that they would be able to stay off CPAP. Faith Myers is currently also very interested in ultrasound. So she did this study looking at a model with various variables that were, from a clinical standpoint, consistent with when you try to come off CPAP, and found area under curve about AUC of 70%. When she added ultrasound to the ultrasound scores, an AUC of 87%. So could you use ultrasound to augment the ability to tell if the baby's going to be able to come off CPAP? And so that's been accepted for publication. We will get that out soon. So that's a potential for can we use ultrasound for these reasons? TTN, typically for transient newborn, you see a double lung point. You'll have some areas that look like RDS, opposed to areas that have A lines and look pretty good, and you'll see that throughout. And that is a pretty good indication of transient newborn that should get better over a shorter period of time, within 2 to 3 days or so. Meconium aspiration is certainly one that if you have bilateral consolidations can be indicative of pneumonia, but in these kids, meconium aspiration, they may give you an indication that their meconium aspiration, their parenchymal findings are more significant if you're looking at by lung ultrasound. BPD is really getting a lot of interest in using lung ultrasound for BPD. And actually, I forgot to put this in here, but there's a talk through the National POCUS Collaborative. I believe it's next week. Almudena from Spain is going to be talking about lung ultrasound and BPD. And there's been a lot of papers now, looking at prediction of development of BPD. A couple of these papers look at by 7 or by 14 days, you're able to predict by lung ultrasound scores whether these kids have developed BPD. And part of the questions that will come up is, can we utilize early scores to adjust our management, other things that we can do to try to, that give us an indication of how we can help these patients or mitigate development of BPD. So a lot more to hopefully come in that area. And then abdomen. So abdomen is thinking about specifically necrotizing enterocolitis. In many institutions, there's actually more interest in using lung ultrasound, or I'm sorry, ultrasound if there's a concern for necrotizing enterocolitis, thinking that ultrasound is more specific and really can look at pneumatosis, see pneumatosis better than you can pick up by X-ray. And there's a lot of discussion on whether that's too sensitive or if that's reasonable to use. And that's mostly done by radiology, but there's considerations that could we as neonatology be able to perform these and get some idea of if they're starting to develop or when to restart feeds. So there is pretty good ultrasound pathologic correlation with NAC, and this is just looking at path findings in association with necrotizing enterocolitis. And there's different stages when you think about the stages of NAC, when you have some thickening and then ultimate thinning and changes in vascularity that you can detect by ultrasound. And can we utilize that? And not many are utilizing that yet, but I know there are a lot of people interested. And if you're interested in a speaker on necrotizing enterocolitis, Yasser Al-Said has done a lot of work on this and is really looking into utilizing this more frequently. And then the last area that I'm going to focus on for diagnostic is cardiac. there are certainly areas where you have patients that are decompensating, and we would prefer not to be, if you can utilize ultrasound to help you diagnose a pericardial effusion more quickly. If you can use one to be able to diagnose this heart is not moving and stop getting volume and give some more pressor support, then why wouldn't we? This was a full-term infant presenting with omphalitis. The team had ultrasound at the bedside, and he just was continuing to be hypotensive, had multiple boluses, and they called cardiology, and they were coming up, but they, should they give more volume? Is it time for pressors? And they really saw the function wasn't great on this patient, so they can adjust or manage it some on this. Now, where there's this discussion, especially when you think about neonatal cardiac ultrasound, is neonates just don't have proof of life. So a poorly functioning LV can be an outflow tract obstruction. A kid who's got you think has meconium aspiration and has whiteout could be TAPVR. And so being cautious with especially with our neonates about putting a POCUS, doing a POCUS evaluation, seeing that good function and treating it accordingly, may be where there's a bit of a challenge to think about what can we do that's best for the patient. If it helps to triage faster and get cardiology there faster because you recognize something is abnormal, I think that's only to our benefit. So there are many names for cardiac ultrasound. It's increasing training that's needed when you think about the pathways for cardiac ultrasound. But there are a lot of benefits to it. You're asking a specific question. It's time sensitive, limited evaluation, refined differential, guide management, all these things that we do from a POCUS standpoint. This is what we want to do. It's the point of having our point of care at the bedside for this reason. And so the timeline for bedside cardiac ultrasound, early in the 90s, and this is neonatology kind of focus, we had clinician perform bedside cardiac ultrasound. That was performed early. We had in 2011, there was initial guidelines from ACE that talked about the use for pediatrics and neonatology for neonatologists performing ultrasound. That was very focused with cardiology having a big role in that paper. And then there's more papers from a pediatric standpoint, and then finally came out to neonatal guidelines in 2024. And the ED has come out, had focused cardiac guidelines that came out pretty early. This was in 2010. So they had goals for focused cardiac ultrasound that looked at pericardial effusion, global systolic function, RV-LV size, intravascular volume assessment, pericardial effusion, and then transvenous pacing wire placement. And there was a recent paper that came out from 2023 on that was Thomas is almost in there's cardiology is on this as well, so we have PICU and cardiology, the recommendations for cardiac point of care ultrasound. And they had fairly similar for what you should look at as a previous paper, and just thinking about preload responsive, qualitative function, and size measurements. But it really talks about excluding kind of the neonate from this with the concerns for congenital heart disease. So this was an update for those 2011 guidelines that just came out a few months ago on guidelines and recommendations for targeted neonatal echo and cardiac point of care ultrasound. So that there's a recognition that even though neonates don't necessarily have proof of life, if we can identify certain things, and also in patients who've had a full echo, identify there's no congenital heart disease, we really should be trying to utilize ultrasound. And so this paper talked about using neonatal performed cardiac ultrasound to look at catheter tip position, pleural or pericardial effusions, eyeballing of the IVC, collapsibility for hypovolemia, and then solid performance. And also talk about if it's the first patient evaluation that you're doing, then having a TNE or a complete pediatric cardiac echo is recommended. Let's not miss the congenital heart disease in these kids. And so really look at that for those neonates. But the things we'll look for are things that we talk about from POCUS in general, looking at functional assessment, is the heart moving or not? Are we looking at fluid assessment, which can be challenging sometimes in these patients who are intubated and with additional positive pressure ventilation, and then pericardial effusion. And again, it's not a replacement for comprehensive echo. And there's a risk for congenital heart disease. There are lots of red flags that we can see that can be related to congenital heart disease that we have to think about. So for the interest, there's actually within American Society of Cardiography, there's now a neonatal hemodynamics special interest group for further advancement of hemodynamics within the neonatal world that's recognized by ACE. And there may be an in-between that we can also think through about how can we potentially not just look at the function and echo and effusions, but can we look a little bit at hemodynamics with some measures? And so this was a 36 and 6 weaker LGA, poorly controlled diabetic. The baby had encephalopathy, perinatal depression, and so was cooled. Was pretty significant pulmonary hypertension. Actually, there was concern for ECMO, and we need to do Remodulin, and what this kid's really not doing great while being cooled. And so the day of life 3 echo and will rewarm day of life 3 is after 72 hours. The patient had a PDA. This is initially was right to left, pretty significant TR. There was flat septal flattening, so pretty significant pulmonary hypertension. I came on call and the patient had, they had already started dose of Lasix, so the baby was starting to rewarm. And so started dose of Lasix, and the kid became more tachypnic overnight. Heart rate went up as was rewarmed. And we noted is just looking at the PDA, the PDA shunting became from right to left, became more left to right over the course of the night. And the atrial shunt was still bidirectional, but the PDA became more left to right. And this is baby who was still on nitric, was possibly had some diastolic dysfunction with being an infant diabetic mother, and then was having faster heart rates. So all this may contribute to some edema, but over the course of the night, looking at echo and looking at X-ray, baby got more edematous or more pulmonary edema. And so we gave some Lasix, rapidly the oxygen, and by the next day when they got a formal echo, the baby had a low velocity left to right shunt. So it changes very quickly, and the transitions in the neonates actually change quickly. So are there in-betweens that we can do for our neonates for being able to assess hemodynamics? And how can that relate between cardiac POCUS and TNE? And so there are many uses for neonatal POCUS. We've got a lot of areas that we can do and more that we're learning. This is a really nice, and the thing about it, and the thing as emphasized with the teams too, is the more that you recognize what looks normal, you recognize when something isn't right. And this was a really nice protocol that came out from the European group looking at the SAFE protocol. And there's also an additional called SAFE-ER that adds in, it's that baby on the right and kind of shows you which directions and where to go for these initial evaluations. But it really takes you through, a few days emergency ultrasound and baby's decompensating. Is there a cardiac dysfunction? Then you get an echo and triage quicker to get cardiology up there. Is there tamponade? Yes, then you'll aspirate. Is there lung slide? Let's go look at the lungs. Is there pneumothorax? And keep moving it down and do it quickly to be able to add to your clinical evaluation. So, I think there's a lot of benefit, a lot of use to learning and to doing POCUS in the NICU. I mean, I always say biased, but I do feel that way. But with that, we have to be able to develop this and really build up the education. And we don't, many of the NICUs and where you're all practicing, there may not be a lot of resources for the neonatologists to be able to learn this. And so they may be reaching out to you all. And when we started the program at Stanford, we didn't have a lot of expertise from a general standpoint for POCUS. And so Burkett was really integral with us in the PICU to really help us from an education standpoint. We had some of the background and put together REDCap, and so they joined us on the REDCap. Burkett and the team really helped us from an educational standpoint and QI perspective, so we can really work together. And at Emory, I've been really fortunate. We have such a great group, and I'm pretty certain I've left off people on here because I know there's more people. And Tim Slesnik, who was actually on one of those cardiac POCUS ACE papers, is on the PICU committee also. So we have a committee on point of care ultrasound quality assurance committee that Pete, who's circled there, is the chair, is set out different work groups to be able to move ahead POCUS within the hospital. And so we'll work on credentialing and education, and we're already doing joint boot camps for fellow boot camps. We started last year, and they'll continue yearly. And we've been really fortunate in the NICU to have a couple of new attendings that have joined us for POCUS interest as well. And Vivek Saroha up there has really started the program before I got here, and so we've been able to move together. And then most recently, just from a national standpoint, we've formed the National Neonatal POCUS Collaborative. So as there was more and more neonatology interest in point of care, there's just not a lot of structure and a lot of questions on how do we do this, how do we get machines, how does this all start? So we wanted to kind of coalesce people and efforts together. So we started this about a year ago. Maki Fraga is our chair, and she's just done such a phenomenal job with getting us working all together to move this forward. So we have an organizational structure. We have exec boards, steering committees, and then we have 5 committees within there. And we partner with the ONTPD, so our fellowship for the educational committee. We partner with, from a research committee, the CHNC, which is our neonatal consortium, that provides, there's a lot of data and great studies and great program development. It's a really nice organization. So trying to be able to get as many people as we can to do some help continue to move this forward. So accomplishments so far through that, and if anyone's ever interested in joining that the website and some of the talks that we have, we said the BPD talk is going to be next week, and that's the third of a 3-part on lung ultrasound in the neonates. So our last webinar, we have monthly webinars. Last webinar had over 130 participants. We've had 5 of them now. We have monthly office hours, provide a platform for anyone with questions, and the people who are moderators oftentimes will bring cases and things to talk through. But we had a lot of questions just on program building, on how do you do this ultrasound, what kind of probes. And then we've done a couple of POCUS programs, how to build a POCUS program, in-person seminars, a couple at PAS and at CHNC in 2023, and they're going to do another one. It was accepted for another conference in 2024 for CHNC as well. We've got a publication out and a couple others that we're working on, and we recently partnered also with the AAP neonatal section, so they can help with, we can get a sense of what's going on in the neonatal world, and also as we start working on guidelines and level evidence, and try to get some bigger papers out altogether. So my hope is that we all just utilize ultrasound in the NICU and just keeps moving forward. This is a text thread that we had with our POCUS team at Stanford, and it had our NPs, fellows, attendings, and those of us who were regularly doing POCUS. And so I actually had left at the time, but I loved getting this text. Don't be jealous. We use POCUS for golden hour, that first hour after birth, before chest X-ray and for pneumothorax, for quickly decompensating baby, and the fellow did a thoracentesis bandstone scan all before the X-ray was able to come. It was too fast, and that was a big thing. They've got to try to record the images so that it and document things so that we can have that for the fellows also when they leave. They have that documentation from a REDCap database that we have that. And so we're just joking there, but it's a regular thing, and they're proud of it, and we really do want to do it. So so thank you again for the opportunity to perform. Really do look to you all in the PICU and all the things that you guys have done and is so regular doing in the PICU. We're getting there from a NICU standpoint, but we've got a ways to go. And so I'm certain that there'll be people within your institutions or NEOs and institutions that reach out saying, we'd love some help on looking at this. And the partnership has just been helpful, so helpful for us. So